and I'm gonna got the recording button. Okay, so I'm gonna be quick. I'm gonna do just 30 minutes so that we have time for the case that is going to be presented, and then we can have discussion on both elements. So the title of this presentation is Resettled Refugee and Migrant Mental Health Practice and Research, and it's based on my research background. I've been working with refugee populations for about uh, 15, 20 years now, and mostly at the border, US-Mexico border, but then also in our own backyard. And so I have a case that I'm going to present based on my experiences at the border, but also just a little bit of background of the mental health issues and some of the research that I've been doing. So, just a brief background on the definition of refugee, which is really controversial. Obviously, in today's politics, it's controversial, but it has been a controversial definition for some time because it's not necessarily inclusive of all populations that we would consider or want to consider as a refugee. And so this is based on the UN Commission. And so it's someone who's owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group, or political opinion, is outside of the country of their nationality and unable to, or owing to such fear, unwilling to avail himself of the protection of that country. Uh, so what is not included oftentimes are individuals that are coming from their homelands that have experienced traumatic environmental events. So that's not typically included. And how this particular definition is interpreted by different countries and different legal groups is subject to major criticism, particularly in the US, depending on what area, what region of the country you were coming in from, being an asylee seeker to getting processed as a refugee, where you're getting processed or hoping to get processed upon seeking asylum is going to vary of how the individuals looking through this definition is going to interpret. So an individual that may have been is part of a social group that has been persecuted, is subject to violence, is subject to extreme poverty, may not necessarily be processed as a refugee in seeking asylum. And we are seeing more and more cases of this. And then individuals that do go through the process and go from asylee ship to becoming a refugee, uh, the battle does not end at that point. It continues and is pretty extensive in terms of what resources are being provided or not being provided. And so I just want to keep the definition in the back of your mind, that despite the fact that we do have guidance, this guidance is not consistent. So there are several healthcare barriers for refugees and migrants living in the US. Obviously, those that are seeking refuge are also a part of many of these barriers, and then some. I'm not going to read through this laundry list, but as you can imagine, there's extensive mental health, physical health, um, public health initiatives that have failed even while individuals have been at refugee camps. And despite UN's efforts and a lot of NGOs' efforts to support these populations, many refugees are coming into various countries seeking refuge with uh, no prior medical history. Not really knowing that they've had medical issues, and there oftentimes are no healthcare providers that are reviewing their cases. When they are processed, depending on what location, I'm going to focus on the US, you can have an extensive amount of healthcare professionals that are doing the screenings and providing support, or very little, if at all. And so the variability of that refugee processing is pretty extensive. The mental health, because I want to really focus on mental health here, the risk factors are quite prominent, and we see both the physical ailments that are impacting the lack of nutrition, the poor living conditions that are impacting mental health, and then pre-existing mental health conditions, untreated mental health conditions that are impacting the physical realm. And so this is from a much holistic perspective, but the mental health risk factors include their experiences of living in very poor living conditions, sometimes going days without even basic needs, food, water, shelter, even at those refugee camps. Physical, sexual, and emotional abuse. Many of the refugees and asylum seekers that I was working with at Matamoros um, had been subject to sexual, physical, and emotional violence. And these may be, very young kids to adults and even the elderly that are experiencing this. The level of undetected mental health illness and poor mental health screening has been quite prominent. And our local agencies, our task force, our small clinics that are helping refugee populations, including and our migrant worker populations, are recognizing that many of the individuals have had poor mental health screening, either through the refugee processing or simply because the focus and emphasis was always on infectious disease and the physical aspects of an individual presentation. You do see several with open wounds, broken bones, displaying a variety of different infectious diseases, and that tends to be the emphasis of the screening and initial care, especially when an individual is going through the asylum seeking to refugee process. And even when becoming a resettled refugee, depending on the location of the US and which communities are taking them in, it really depends on the extensiveness of mental health services. I will say our area is pretty good. There have been fluctuations in terms of the sheer number of individuals coming in from various countries and whether or not communities have been able to support holistic care, supportive care. Sorry, I'm in somebody's office at Mercy Health and their phone just went off, so apologies. Just hitting people's buttons there. Um, what we're typically seeing in our own communities with, say, our Nepali speaking Bhutanese, we're seeing poor nutrition, a history of poor nutrition that has had uh, an impact on even mental wellness and high suicide rates, as well as feelings of anxiety, feelings of depression because of their past experiences, either living in a refugee camp or not meeting the basic human needs, has really impacted the overall mental well-being. And so our agencies, our clinics in Northeast Ohio have been doing the best they can to deliver more of the holistic package of healthcare and not just focusing on the physical. I will say that the relocated individuals that we do see in Northeast Ohio have come from resettlement camps, cities that they've been transported to and from with very high crime rates of sexual violence, physical violence is very high, and it often goes undetected. These are the things that obviously individuals do not necessarily want to talk about. After being resettled, you want to start new, you want to become enculturated into a community. And so, besides the stigma, there is the fear that if you talk about those things in some cultural groups, that it's going to come back and that you're going to have re-traumatic experiences, but also experiences again of the normal fear. Our Nepalese speaking Bhutanese community struggles with even the concept of mental health. This is not something that has been widely discussed, even acknowledged within pockets and subpopulations of that community. So even having discussions about mental well-being has been a challenge. Some of the mental health illnesses that do and may go undetected, obviously the post-traumatic stress disorder and elements of sexual violence, experiencing, witnessing violence, issues of torture, war, imprisonment. I have a dear friend now that I've developed a relationship over the years who was in a refugee camp on the other side of Matamoros and experienced just about every one of these elements of post-traumatic stress disorder. And it's going to relate to one of the cases I am presenting. And in talking with some of the NGOs, the medical professionals, some of the psychiatrists that were working with uh, the resettlement group that was in southern Texas, they said it's even difficult for them to fathom the amount of trauma that a single individual has experienced. Depression, anxiety, there's an increased risk of schizophrenia, and then drug and alcohol abuse. Individuals that have never had drugs and alcohol until they were trafficked and then have developed addiction, problems with addiction. So here's my mini case, and this is based on a real situation. It was a Guatemalan family, Maria Morales and her two children, Leah and Hector, and they were seeking asylum after her husband and oldest son were brutally murdered by gangs in Guatemala and in front of the entire family. And not to be too gruesome, but they were decapitated in front of the two children. So Maria and Leah were also sexually assaulted traveling by foot to the US-Mexico border. And Hector's fingers on his right hand were removed by a machete from some of the gang violence. They wanted to actually take him because they were taking males into the gangs. And so that's why Maria left with her two children. The medical NGOs and Catholic charities, I worked with the Catholic charities with many of these cases. And there was another NGO at the border that provided legal aid. And so they collaborated to support the family during their processing to become refugees. Well, the family, I was there in the initial screening, and then they were there for a week. There was a unique community in the refugee encampment. The family was very much protected by the other families, and they were coming from all over South America and even some of the African countries. And so they had this very protective community at the border. And so they would get information, they would try to be able to see what they needed to be heard for their case. Well, U.S. officials, they were able to get an interview with U.S. officials, but were denied asylum seeking or refugee status. That they were claimed that they were not believable of their violence, despite the fact that they had a physical hand removed. There was clear evidence from the NGO doctors that sexual trauma took place. And so there was clinical evidence. There was evidence of from police about the particular gang. So there was an ample body of evidence, but they were denied. So then, after one of the legal representatives was working with the NGOs, they actually helped Mariana two kids and basically training them what to say, how to say it, trying to fit within the UN and US based definitions of what constitutes a refugee. They were eventually granted status. When they came across the border, they had ankle bracelets on all of the kids and the mother, keeping track of them until they were secured at Catholic charities, got coats a bag of clothes within a 12-hour period, and then sent on a bus to Maine, to Portland, Maine. Never have been into a cold climate ever in their lives. And that was it. No money, just a bag of clothes and a bag of lunch items. And so a lot of the considerations, basic needs were not being met even during the refugee process. Um, there needed to be continuous medical care. Not one of them actually had received medical care while they were across the border on the other side of Matamoros. They had a infectious disease screening, and that was about it. And then no mental health care whatsoever. And the only preparation for the long travel was due to Catholic Charities because they have a an agency there that provides clothing, basic food just for the traveling. So it was pretty alarming. And this is just one out of several families. And so we're relying heavily on our communities, refugee task forces, agencies, to collect some of these basic needs. The US government and other countries' governments does provide some resources through the resettlement process, but they're not sustaining. Typically, access to housing, legal representation, health care, and so forth is oftentimes limited in a 2 to 4 year period. And the expectation is that you begin work and that you acquire these things on your own or based on agencies and community groups. And so we rely heavily on our refugee task force, our agencies. We have several in the Northeast Ohio area, but a lot of these agencies are struggling financially because their funding has been cut. From an ethics, public health standpoint, I look at this from an integrated framework, looking at a capabilities approach, which I'll go into at the global and national levels, a communitarian approach at the community level. And that community, like I mentioned, could be at the level of the refugee camp or the encampment to actually the resettlement community. And then the individual narrative approach, where we have to hone in on the nuances, not assuming every individual coming from a particular country of origin or experiencing a traumatic event has that same narrative. And like I said, the layers of a mental health and physical health issue can be quite extensive, even with a single individual. This is, I know it's a heavy slide here, but the capabilities approach is a social justice approach that was originated by Marta Sen, who was focusing on actually economics, and then taken on by philosopher and social justice theorist Martha Nussbaum. And this approach expands our notion of human rights and some of the UN basic concepts of what rights do we all have. And so she came up with these 10 capabilities, and it's the capabilities that allow humans to flourish. And how we flourish really depends on the interconnectedness of our communities, but also a recognition of those that are in power, of these core elements that every human being should um, not go without. So, life, bodily health, bodily integrity, everything down to recognizing the importance of play, making sure that they're safe communities. I was really impressed by Catholic Charities and some of the NGOs at Matamoros, but also some of the other borders that I've been to, where they try to create a safe space for the children, playing, some education, talking about nutrition, just so that if and when they're able to be resettled, that they start having that sense of safety and comfort and the ability to flourish. But these are the ten elements. I could go, for days on talking about these. But from a justice perspective, it really expands upon some of the legal aspects of what is a basic human right. The other element is communitarianism. Like I mentioned, it is a theory that we often use in ethics and social justice aspects of focusing on how communities can not just build connections, but also shape identities, focusing on what with this topic, particularly of what are some of the common goods, common elements, how do we bring those capabilities into our community? And to ensure that individuals are not isolated selves, based on the culture within a community that gives us insight and humility about a particular group of people, but then the importance of taking that element of culture and then understanding it on a more personal, individualized level. The communal values are established based on shared cultural and social political beliefs and attitudes. And what's interesting with many of these refugee camps, and I've known individuals who've been living in refugee camps for 20, 30 years even. When you talk about some of the Nepalese speaking Bhutanese that are in our community, that they create a culture within that camp. And it's often hard for outsiders, healthcare professionals that are not used to um, these different communities to understand there's a culture before the refugee camp, at the camp, and then post camp, and trying to put those parts and pieces together in a deeper understanding of who that individual is, where they came from, whether it's the trauma that they experienced or their goals and values and how those were shaped. And that gets into that narrative approach, really looking at the individual. And I will say we need to do better from a healthcare perspective, a mental health care perspective, in recognizing the individuality that each individual brings to the clinic. With Maria and her two kids, I mean, Hector had a completely different perspective of what he experienced. I mean, he had the physical violence, he didn't have the sexual violence, but having the fear of being taken away by a gang because that was the threat. He still has nightmares. We actually keep in touch with this particular family, but he still is experiencing post-traumatic pretty stress pretty bad. Our advocacy programs and agencies continue to address these needs, but again, there's only so much resources, and so we have to expand our network beyond Asia Inc. and some of our clinics that we are working with, the Refugee Task Force of Akron, for example, and really dig into many of these elements that are coming up. I will say the increase rates of suicide are alarming. And it's it's not that individuals go necessarily untreated, but they're undetected. It's the individuals that have gone undetected that do not want to talk about any of the mental health issues that are more susceptible. So, some of the pragmatic actions, besides utilizing a more integrated framework from a capabilities, communitarian, and narrative approach, these were kind of my life lessons in working with these populations and some of the ongoing research, particularly in the mental health area. Um, for example, refugees have high expectations of American clinicians. There's a honor and a respect of the clinician, and sometimes that honor and respect also is overshadowed by the fear to actually disclose the more personal elements of somebody's life. Advocates don't often look at individuals, but groups. I've caught myself doing that at times in conducting various different research projects. And it's something that you have to just continually be mindful of. Something that I can't emphasize enough, and I'm fearful, given that many clinics are in jeopardy or closing down. Individuals are not going to them because of fear of ICE coming in, is the suicide prevention. and how do we get communities to educate, but also show and illustrate some safe opportunities for individuals that may not feel safe even going to the clinics anymore. So this list is not exhaustive, but it's the things that I have learned over the few years of doing this work. And I continue to really want to work with populations, especially now. So some references focused heavily on the social justice elements and mental health in 2021 and 2022, especially during COVID. And I want to revisit that type of work, especially now, given kind of the political environment. So, all right. Any questions? And hopefully I gave you guys a nice half hour so you have your case study and other discussion.